Let's start the recording now. There we go. All right. So yeah, welcome everybody to our last community call of 2021. It's gone by very quickly. But today we have Dr. Keshavan with us. So needs a very little introduction. I'm sure people have heard from Kesh before, but just by brief introduction, Dr. Keshavan is the Stanley Cobb Professor and academic head of the Harvard Department of Psychiatry here at Beth Israel Deaconess Medical Center. He's been doing early psychosis intervention research for many years, has published many papers and books in this topic. And today we have the privilege of hearing him speak a little bit on assessment and diagnosis in early psychosis. So what are the things we need to think about when somebody first starts presenting with psychotic symptoms? So hoping this can be an interactive and interesting discussion for you all. But without further ado, I will pass it off to Dr. Keshavan.
Okay, thank you very much, Kelsey. Good morning, everyone. Good to see everyone before the holidays. Hope you're all getting ready for those. So let me share my slide here. Can everyone see? So the topic that we're going to discuss today is something that is important to everyone who does early psychosis intervention work, whether it's in research or in clinical service. And, first of all, I want to say that quite often we don't think about the diagnosis and just get on with doing whatever needs to be done, which is understandable. But not having the right diagnosis or not having a comprehensive assessment early on would be like putting the cart before the horse and will lead to possibly a lot of wasted time and inappropriate intervention. So, again, this group, I don't have to convince you that an early diagnosis is as important as early intervention. So there are the three main points that I want to discuss today. First of all, why early intervention and early detection, early diagnosis and assessment. And secondly, what are the key elements of psychiatric assessment in patients with the early course of psychotic disorders that, as in any elsewhere in psychiatry, that we have to keep in mind. And thirdly, and which is the larger part of my presentation, which hopefully will be interactive, is how to make sense of the findings while we are assessing people in the early course of psychotic disorders. So the first question, very briefly, there are three main reasons why it's important to have an early detection effort. First of all, we know that psychosis is an illness that evolves in a number of phases, from the pre-morbid phase, where there are subtle cognitive or personality-related alterations, and then a period of variable duration with declines in functioning and cognition and subtle positive and negative symptoms, which we call the prodrome or the clinical high-risk state, for months or sometimes years before the onset of the first full-blown psychotic episode. And then there is the psychosis, which begins typically in late adolescence or early adulthood, and a series of recurrent psychotic episodes may follow, followed by a chronic, stable, or residual phase of this illness with a post-illness onset functional decline. So psychosis is really a late stage of what we might later call schizophrenia. And so it's important to begin having our diagnosis even before psychosis emerges, but certainly early in the psychotic episode. And the first reason why it is so important is that the longer the delay from diagnosis to treatment is, or from the onset of symptoms to treatment, the worse is the outcome, whichever domain of outcome that you look at, whether it is symptomatic, social, interpersonal, employment, quality of life, all of those are affected by the so-called duration of untreated psychosis or treatment delay. The second main point is that the longer the illness goes without good treatment, without appropriate treatment, the worse becomes the cognitive impairment, which has in turn secondary consequences on functioning. Thirdly, the longer the illness goes, there is evidence that the more the brain dysfunction sets in and may move into structural alterations. What you see there in the red regions is the gray matter atrophy or thinning of the cerebral cortex that happens in the first few years of the illness. With that said, what are the key elements of any psychiatric assessment in patients with serious mental disorders, and certainly in patients with early course psychotic disorders? I know this group is a mixed audience with some very experienced clinicians and some beginners. So I'm going to go with some basic principles first, and then go into the more specific details with case examples. So the basic principles that we all should keep in mind is that the initial intake psychiatric history needs to be comprehensive. That includes a collection of the chief complaint and the history of present illness, a review of the past history, medication history, personal, family, and social history, and a review of systems, just like anywhere else in medicine. Now, in psychiatry, what in the rest of medicine is a physical exam. In psychiatry, it takes the shape of mental status exam. And this is done systematically and across a number of domains. And for ease of remembrance, the way I remember them is the ABCDs of the mental state: appearance, behavior, conversation, delusions, emotional state, higher faculties, general intelligence, hallucinations. The reason hallucinations come later is questions of unusual psychopathology, such as hallucinations, should be kept to a later part of the interview rather than at the beginning. There are a lot of observations that you'll be making in the mental status exam, even you begin to ask about voices and so forth. Insight, judgment, and of course, in terms of higher faculties, in the bedside mental status exam, there are some basic things that you would want to ascertain even before one orders a cognitive testing battery. These include what I use as the mnemonic oracle: orientation, recall, attention, abstraction, calculation, language, and executive functions. When the patient walks into your office, you begin already making observations, looking at the patient's facial expression, posture, the way the person is dressing, personal hygiene, and motor behavior components, including gait, freedom of movement, handshake. These days, you, of course, have to be careful about handshake, but you probably will get a lot of information even without the handshake. The way the patient is keeping a social distancing in these days and ages of social distancing can be very revealing. Look for any involuntary or abnormal movements, the pace of movements, purposefulness of movements, and degrees of agitation. Conversation. When you get to talking to the patient, there are two key elements in your assessment of the patient's speech. One is the form of speech, and the other is the content of speech. So assess the form of speech by looking at the rate of speaking, the spontaneity, the intonation, whether there is a monotony or whether there is a variation in that intonation. A loss of or monotonous speech is often a symptom of neurological disorders. It's called aprosardia. volume of speech, and of course, the form and content of speech. Now, I'll delve a little bit into form of thinking, which all of us should have an idea as to how to assess the form of speech in patients that come into our clinic, psychosis clinics. Because the form of speech and the content of speech are what gives us the picture of what is going on in the mind, as this the classic sculpture by Rodin on the thinking man reveals. Speech is the mirror of the mind. Thinking is the mirror of the mind. So let me ask you a few things here. So when assessing speech, you're really looking for whether the speech is goal directed or not. So let's see this one here. Patient comes in and says, I was at home. You ask her, what brings you here? I was at home. I had a headache. I told my husband, and the husband got me to the clinic, and here I am. So how would you characterize a sample of speech like this? Anyone? You can speak of. This is not a large group, so anyone wants to comment on whether this is goal-directed or not? Kelsey, maybe?
Yeah, seems very goal-directed to me, pretty linear.
Yes. So this is a normal goal-directed speech. Okay. So let's look at this one. And I'll point to some of you, and maybe you can say what it is. So maybe the next person I'll ask is Alyssa. Let's see. I was at home. I felt a headache. I told my husband, maybe you know him. He works in a hospital too. He always cares for me too much. And I'm here now. So what do you think is the nature of the form of speech here?
It sounds a little less goal-directed than the last one.
Yeah, is there a name for this kind of speech? Sort of beating about the bush. This is called circumstantiality in psychiatric criminology. A lot of otherwise healthy people have that, including some teachers, but not necessarily a sign of psychopathology. It could be. Some people with schizophrenia, after they get better, remain circumstantial in their speech. But it's in and of itself, it is not a sign of psychopathology. So let's take a look at the next one. And let me see who I can ask about this. Raquel, maybe you can answer this. I was at home. I had a headache. So I told my husband, he's really great. If only he would spend more time with me and children. Do you have children? I have 3 girls. Okay. Or anyone?
See from Emily in the chat, tangential.
Tangential, absolutely. Yeah, this is tangentiality. Also can be normal, but can also be a sign of psychopathology, but not a definitive sign of psychopathology. Great. Okay. So next one. I was home. I have a headache. I told my husband is really great. If only he would spend more time with me and children and cats and rats and bats and smuts and drat. Any thoughts?
Is this
I'm not
climate
seeing
preservation?
anything in the chat. So Sorry, go ahead.
Is this clang associations? These kinds
Yeah,
of
absolutely. So there is clang association here, but there is more than clang association. Yeah, this is an example of flight of ideas. So my slide is not moving for some reason. Let's see. So do you have children? I had 3 girls. So it doesn't come back to the point, has been jumping from topic to topic. And so this is a sign of flight of ideas and clanging, which can be a characteristic feature of bipolar mania. I think my last one, I was home. I have a headache. My mother is growling in my head. I should have done this earlier. If only I had focused more on Jesus before. Do you see what I see? I see birds. I have 5 birds. Any thoughts? What is this an example of? Emily, maybe you can answer.
I would say that's acute thought disorder.
Yes. It's also called loose associations. It's considered a sign of schizophrenia if you can rule out another neurological cause for the thought disorder like aphasia. So there is a loss of logical connection between one thought and another thought. And also there is one other thing here. She combined girls, which was on her mind, and birds, which she was seeing. And she came up with the word birds. Is the name for that?
Is that a neologism, Cash?
Yes, absolutely. That's a neologism. Yes. So neologisms, again, in the absence of aphasia, is considered a classic sign of schizophrenia. So it's important to keep that in mind. Now let's talk a little bit about delusions. Delusions are fixed false beliefs firmly held in spite of contradictory evidence. Many types of this. I won't go into a lot of the details, which you all, I'm sure, know. Delusions of control, erotomanic delusions. Usually a person of a higher status is in love with the patient. Grandiose delusions, somatic delusions, like the brain is melting away, things like that. Delusions of reference and persecutory delusions, others are trying to cause harm and so on. But it's important to keep in mind that not every time that the patient says that they are being followed necessarily means that they have a delusion, especially these days, where we are constantly following somebody else or being followed on various forms of social media. So the important point is that whenever a patient is saying something that appears delusional, check whether there is some possible pinch of truth in that. And one should always consider that as a possibility. A delusion is a fixed false belief that is not in tune with sociocultural surroundings. That's an important principle to remember. Assessing affect is not one thing. One has to look at emotional state of the individual by looking at the appropriateness, the nature of the affect, the appropriateness of the affect of the situation that they're in, the appropriateness or congruence with the thinking process, the intensity of the affect, the range of movement of the affect within the given interview, mobility, and the reactivity to changes in conversation and so on. All of those are important to assess in the context of a mental status exam. Insight. So insight is again not one that is multidimensional, and a person might have full insight. So, for example, if the person hears voices, but he or she is aware that this is not something they should be hearing, it could be part of an illness, that is awareness. And they may be attributing it correctly to an illness and not to a chip inside their brain. And they're aware of a need for help, and they're aware of and adhering to treatment. So these are the four components: awareness, attribution, appreciation of need for help, and adherence to treatment. And poor insight could be one or more of these. There are many patients who are fully impaired in their insight with a lack of awareness and a misattribution and a lack of appreciation and need for help and a lack of adherence as well. But there are some who have just one aspect of it. I hear my grandmother's voice, and don't you hear the voices? That is kind of a lack of awareness issue. But then if the person also says that I hear this coming from this chip implanted in my tooth by my dentist, so you have lack of awareness and a misattribution. I hear this voice, and I'm sure everybody hears this voice, and I don't need help for it. So that includes lack of appreciation for help. I may need help, doc, but I'm not going to take it. So that is lack of adherence. So all four components can be there in part or in full. So that's important to keep in mind. What is judgment? So judgment really refers to a moral decision as to what is the thing to do, the ability to anticipate the consequences of one's behavior and make decisions that protect oneself and others in the context of one's own compass. So how do you test that in a mental status exam? The standard teaching is that you use one or other hypothetical situations. You can come up with any of your own in the context of the patient's history. The classic teaching example is if you find a sealed, stamped, addressed envelope on the street, what do? And a classic, poor judgment would be, I'll open it, and if it is a check, I'm going to pocket it and maybe try to cash it. So it's just, these are extreme examples, but assessing judgment is not just by hypothetical systems. I won't go into rating scales and so on, which probably will be in some other setting that we can be talking about that. Can everyone hear me? I'm getting an internet unstable signal here.
You cut out for a minute, but you're good for now.
Okay, great. So how do we make sense of our history and mental status exam, that the data that we have collected so far? And I'm going to go through a few key elements of our thinking process in terms of how to make sense of findings. And before I do that, let me give you a brief primer on how I think about diagnosis in our lives. And when a patient walks in, the first question you have to ask yourself is this psychosis? And if you believe that it is indeed a psychotic episode that the patient is presenting with, the first question to ask is this explained by a medical illness or a substance abuse or a developmental disorder? So in which case, you would think of either psychosis secondary to a mental illness, a primary developmental disorder, or a psychosis secondary to a substance abuse. Having considered that question, the second question to ask is, are there prominent mood symptoms in the context of this psychotic illness? Yes or no? If the answer is yes, then you ask the question, all just affective psychosis, or is there psychosis outside of the affective episode? Is the psychosis outside of the you would consider schizoaffective disorder. If there isn't, and psychosis always is in the context of episode, you consider psychotic affective disorder. Third question is the psychosis mainly characterized by non-bizarre or plausible delusions and nothing else? If that is the case, you would think of delusional disorder. But if there are more than non-bizarre delusions, such as hallucinations and delusions that are incongruent with thinking, with bizarre delusions, you would ask the question, how long has such a psychosis existed? If it's less than a month, you would consider a brief psychotic disorder. If it is 1 to 6 months, you would consider a schizophreniform disorder. If it's more than 6 months, ask yourself, is there a functional decline as well? In which case, you would consider schizophrenia as the diagnosis. And if you can't make up your mind, the slide is not moving here. Let's see. So if these criteria are not met, which are the criterion set A for schizophreniform or schizophrenia that you get, if none of those are met, you can't make up your mind. There is still a category which, unfortunately, everybody or most people use if they don't have enough time to assess or if they don't have enough information. That is the ragbag category of so-called psychotic disorder, not otherwise specified. So, my hope is that we use this category as infrequently as possible, because this is generally an admission of ignorance. But, in some cases, you just don't have enough information and you will have to use that. So this is kind of a very quick primer on a differential diagnosis of psychosis, but we will come back to this after a few that we will go through. So as I said at the beginning, there are three key questions you have to ask. Is this really a psychotic disorder? Does a medical condition or a substance use or a developmental disorder better explain the psychosis? And the third question is the psychosis not better explained by a primary psychotic disorder or another mental disorder? Let's take the first one. And this one was a case that I encountered early on in my career, and it was quite eye-opening for me. And so let's think about this. This 29-year-old recently married farmer in India is seen in the outpatient services. This was me as a resident, for grandiose beliefs that he has the strength of an elephant and that he can father thousands of children at once. He has a prior history of depression and anxiety, but denied any other psychiatric symptoms, and is currently anxious, irritable, somewhat agitated, and depressed. He occasionally uses alcohol, but denies other substance use. He is admitted for further assessment. He has had some difficulties relating to his wife, but otherwise denies any psychosocial stressors. Any thoughts on this case? What would be your differential diagnosis? Maybe, Alyssa, you can put out the first survey question. Are people seeing the survey?
Yeah, it looks like it's showing up. We're getting some responses.
Is there a feedback? I mean, can you share the summary responses?
Yeah,
Sure,
let's-
yeah, we'll give it a few more seconds and then we can put the
Sure, yeah,
responses up.
yeah.
Mhm. Okay, so
Okay,
here are the
okay.
results.
All right. So 1/3 of you said it is a mixed affective episode. 1/3 of you said bipolar with psychosis. About 1/5 each said major depression and other. Specify in chat. Any specifics are coming out in the chat? Okay. All right. So here is the actual answer. So physical exam, it turned out that the patient was admitted without a physical exam. And on the ward, it happened to be that I was the resident, and the physical examination revealed elephantiasis of the testis. So when the patient said, I have the, the power of an elephant, I can impregnate, or I can father thousands of children. He was actually, in his own way, referring to his elephantiasis of the testis, which had not been diagnosed previously. So he was actually saying something about the truth. So always consider the possibility that there is some element of truth in what the patient is telling us. So this was kind of a dramatic example. You may never see such a case, but I brought this up just to illustrate this point. Let's think of another one. Also raises the question of the same question that we raised. This 13-year-old girl currently in 8th grade and has a history of ADHD, brought by her mother for concerns of declining academic grades, mostly Bs, from mostly Bs to mostly Ds or Fs. She's also beginning to talk more about her telepathic abilities. She had used marijuana a few times, socially withdrawn, sometimes sad, sometimes has to be encouraged to take a shower, some family history of psychosis, unspecified. So when you see her, she's dressed in goth attire, black t-shirt with images of letters dripping blood. Her affect is blunted, slightly more animated when her parents leave the room. She thinks people at school are spreading rumors about her sexuality, but she's not sure. Over the last month, she occasionally hears whispering sounds, calling her name and saying she's worthless, even though she knew it might all be in her head. So, Alyssa, the survey. Let's give it a few seconds, and then Kelsey or Alyssa will share the results. Do you have the answers? Yes. So the majority of you, 50%, came up with the attenuated psychosis syndrome. And about a quarter of you still called it schizoaffective disorder, and a lesser number schizophrenia. So this is worth thinking about. Why did 50% of you say this is attenuated psychosis syndrome and not as a schizoaffective disorder? So it's worth thinking about, where do we draw the line between psychosis and attenuated psychosis? The key point is that the voices she heard, she had some level of insight. It might be all in my head. And the delusional ideas she had, she was not so sure. So there was no full conviction. So these are the two things that really gives away the possibility that this might not yet crossed over into psychosis. So that brings us to the diagnostic criteria for attenuated psychotic syndrome. The DSM-5 has developed a proposed or provisional criteria, which where it says the following should all be present. Number one, at least one of these symptoms in attenuated form with intact reality testing, delusions, hallucinations, or disorganous speech, which she clearly has delusions and hallucinations, but they are not with full conviction. The question then is it frequent enough? And I said that her symptoms have been there at least once a week for the past month. So she meets criterion B. And criterion C, it began about a year ago. And I did not say whether it was significantly worsened or not. So, it either began within a year, the last year, or significantly worsened within the last year. So either way, the patient would meet the criterion. And it certainly is treatment seeking, otherwise she would not have been brought by the family, and not better explained by other diagnoses. She had an occasional cannabis, but would not explain this level of symptom severity. And she has not met criteria for any DSM psychotic disorder. So it's important to think about how do we determine the presence of psychosis? And we have a scale called SIPS, which many of you are familiar with, the structured interview for prodromal symptoms, which gives you a way of categorizing the various psychotic and negative symptoms into rating scores of 0 to 6. 6 is fully psychotic. 3 to 5 is in the attenuated range. And that is what this patient would have probably manifested. And let's see. So that is what gives you the diagnosis for attenuated psychosis syndromes. So the next question we have to think about is this psychosis not better explained by a primary psychotic disorder or another mental disorder? So let's think about this case. Also, a patient that I took care of many, many years ago. This 42-year-old woman was admitted for a recent onset of delusional beliefs that she and her children are in danger because neighbors pump fumes into her house. She has changed several apartments as a result of this. On interview, she reports auditory hallucinations, but no visual or auditory. She's blunted in her affect, has some fixed persecutory delusions, and has mild deficits in verbal memory. Medical history is unremarkable. She takes some steroid inhalers for bronchial asthma. Apart from a common cold in which she has a clear-cut nasal discharge, no other upper respiratory symptoms. So let's run the survey now. Kelsey, okay. We might be ready for the answers. Okay, so everyone, the majority was in the other category. So are there any answers in the chat as to what it might be? People are not comfortable with the diagnosis of schizophrenia here. People not comfortable with psychosis triggered by steroids or upper respiratory infection, but something you're all scratching your head. What might it be?
The thing that stands out to me in this one, Kesh, is the olfactory hallucination rather than auditory or visual. Good
point. So always ask yourself the question, not only is this psychosis, but also is this psychosis atypical? Someone who has a hallucination in a single modality like olfactory hallucinations is always a suspect. And is there anything else atypical about this case?
Her age as well.
Yes, absolutely. So age of 42 as a first onset psychosis, not that unusual. Women tend to have a little bit later onset of psychosis, but not 42. Again, some women might have psychosis first episode at age 42. We use the word late onset paraphrenia for that, which is particularly more common in women. It's not extremely uncommon, but it's a totality of the picture of a isolated olfactory hallucination and a later age of onset, which should trigger in you a suspicion of something else going on. So it turns out that I was called in over the weekend following admission by a smart nurse who said, doc, this patient is continuously running nose and this crystal clear nasal discharge doesn't seem to stop. What should I do? And, in such situations, we always ask for an examination of the nasal discharge, which I asked for. And it turned out that she was leaking cerebrospinal fluid from her nose because she had a colloidal cyst of the third ventricle, which was leaking from the base of her skull. So now it all makes sense, because when there is a colloidal cyst of the third ventricle, which is pressing the hippocampus, that can cause both psychosis and the memory problems. And of course, when it is very close to the base of the skull and coming through the sinuses, it causes CSF rhinorrhea. So she was immediately taken to neurosurgery, operated, and her psychosis went away. So not common, but you do see these kind of cases once in a while. So when there is a first episode of psychosis that you encounter, always ask for what else might it be? It could be a head injury, it could be lupus, it could be, these days, more and more cases are appearing of NMDA receptor encephalitis. They're all autoimmune conditions. It could be a congenital disorder, villocardiofascial syndrome, or the so-called 22q deletion syndrome could be a cause for psychosis. Toxic causes, which include drugs of various kinds. Cannabis is most common these days. Cocaine, MDMA, amphetamines, PCP. It could be iatrogenic, steroids, antimalarials, antituberculars, space-occupying lesions. I've had several cases in my career where the initial presentation was with psychosis, turning out to be a brain tumor of one kind or the other. Metabolic conditions, Wilson's, metabolic leukodystrophy, endocrine conditions, dietary, pellagra, B12 deficiency, neurosyphilis, HIV disease, even COVID. There have been reports of psychosis in the context of COVID-19. And of course, the later age disorders like dementia and Parkinson's and multiple sclerosis. Seizures, very important to keep in mind, especially if the psychosis is episodic. And endocrine problems like especially thyroid and hypothyroid to be considered. And all of those suspicions would certainly lead to specific tests. And I'll, in a later slide, show what are the basic workups for a first episode psychosis and what are all the tests that one would want if there is a higher index of suspicion of some kind or the other. Neurological examination is important as well. Whenever you have a questionable mental status exam, which is pointing to a neurological condition, look for reflexes, pupils, Parkinsonian signs, copper rings around the cornea for Wilson's disease, diminished vibration sense for B12 deficiency, nystagmus incoordination for Wernicke's encephalopathy, which is due to alcohol, and apraxia, gait problems for normal pressure hydrocephalus. A recommended workup for a first episode psychosis patient should always get a complete neuropsychiatric and medical history, a neurological and physical exam, neuropsychological testing. I think that this should be done routinely in all first episode psychosis cases, even though unfortunately guidelines are quite variable about that. All first episode patients should have at least some basic metabolic screen, including CBC, glucose, electrolytes, thyroid function, liver function tests, and urinary drug screen. Second line assessments, if there is a specific reason to ask for other tests, which might include tests for infections, heavy metals, autoantibody titers, chromosomal analysis, urine toxicology, brain scans, EEG, and MRI, and cerebrospinal fluid analysis in select cases. So let's go to the next case. 19-year-old sophomore, increasingly bizarre behavior, paranoid thoughts, social isolation over the past month. She has begun smoking marijuana at the age of 16, and this has escalated to daily since the last 2 months. So when examined, she shows signs of paranoia, reports that her other students in her dorm are stealing from her, trying to poison her. She sometimes sees pictures in the walls becoming alive. In the mental status exam, she's anxious with a labile affect. Thought processes are goal-directed. Cognition is intact. Mild distractibility. Insight is fair. She's aware that she's losing it. So let's think about what might be the potential differential diagnoses. So the second part of her case, do we have answers for the first survey just now? Yes. So the two main possibilities that were raised were psychosis secondary to cannabis abuse, which was the most likely. 80% of you said that, and about 20% of you said it is schizophrenia triggered by cannabis. So this is what I would have said as well, but let's see what happened to her. Because even though we don't have a specific diagnostic test to say that this is cannabis-induced psychosis, often time gives away the answers to us. Part 2. So all her labs were normal except THC, which was positive. And after hospitalization, she was treated with 3 milligrams per day of risperidone. Her symptoms did not appear to improve, and she was discharged against medical advice. So even without psychosis, without risperidone, she was discharged. And she declined medications in the early psychosis clinic, but agreed to weekly psychotherapy and substance use counseling. She remained abstinent for over 6 months from cannabis with no evidence of psychosis. However, she presented to the ED with severe anxiety and visual hallucinations after she had partied with her friends smoking cannabis. So this information, if you run the same survey again, Alyssa, let's see what the answers now will be. Okay, let's look for the answers. So now actually psychosis secondary to cannabis abuse went down. Yeah, I want to ask the question to the audience. Why would this be schizophrenia precipitated by cannabis as a more likely possibility? So here is a individual who had psychosis in the context of cannabis escalating use. And then she did not get any antipsychotics. And even so, with cannabis abstinence, the psychosis went away. And the psychosis did not return until she started using cannabis. Would that not indicate it is more likely to be a psychosis secondary to cannabis abuse as opposed to schizophrenia precipitated by cannabis? I would be curious about anyone who can explain why this is more likely to be schizophrenia triggered by cannabis. So either speak up or put it on the chat. Anyone? Here's a classic AB design. A followed by B, that is cannabis followed by psychosis. And then the psychosis goes away. And again, cannabis comes back and psychosis comes back with a full resolution in between. Anyone who would argue with me on this? Let me look at the chat. This is very important, guys, the answer to this question, because you will see this sort of scenario all the time in practice. It's important to have a way of thinking about this that would support your conclusions. Let me specifically ask, Emily, what do you think? You work on cannabis quite a bit, psychosis in the literature.
I would say this is schizophrenia that worsens with acute, like in the, if she smokes, she gets an exacerbation.
Well, here is someone whose psychosis went away without antipsychotics and only came back in the context of cannabis use.
Sorry, I missed that part. Yeah, so then I would say it's probably a cannabis-induced psychosis.
Yeah, so that's there in the part 2. So I just this is very important teaching point. If there is a clear-cut situation where this only came in the context of cannabis but did not come without antipsychotics, to me that would be a clear evidence of this being primarily a cannabis-induced psychosis. Anyone who would argue in a different way? Well, anyway, think about it, and we can have hopefully some time to discuss at the end as well. So let's go to the next case. This young lady is a woman who presents with psychosis relapse. She has been smoking marijuana daily, especially after she broke up with her boyfriend last month and moved back to live with her parents. She hears multiple voices of women competing with her for her boyfriend's affection. She had been treated for ADHD between age 7 and 11. She has difficulties trusting with people, has few close friends in high school. She also begins smoking cigarettes daily and marijuana occasionally to relieve stress. Her first psychotic episode was age 19 when she started college. Her psychosis improved with cannabis abstinence and paliperidone injections, but she could not get back to school because of continuing paranoia, trouble concentrating, and poor motivation. So let's see what the questions are. Yeah. Okay, let's look for the answers. Yeah, so the majority of you said this is schizophrenia with secondary cannabis abuse. So clearly she has many features of schizophrenia that cannot be explained by cannabis alone. The symptoms that are persisting, cognitive impairments, poor motivation, and her social isolation. And the cannabis does not appear to be particularly heavy, and not necessarily always related to the psychotic episodes. So that's the kind of differential diagnosis one would often face with in clinical practice. Let's move to the next one. So there is literature on as to how one distinguishes between idiopathic or primary versus cannabis-induced psychosis. Primary psychosis tends to, those with schizophrenia, may show cannabis in urine toxicology, sometimes positive, variable use of cannabis. Symptoms appear even before heavy substance abuse. Symptoms may persist despite drug abstinence. Antipsychotics markedly improve symptoms. Most often they present with delusions, hallucinations, and thought disorder. They relatively have less insight about their psychotic illness, and they characteristically show more disorganized thinking, more often have a positive family history of psychosis, premorbid maladjustment, and schizotypal features. By contrast, cannabis-induced psychosis there is a temporal relationship between heavy cannabis use and psychosis. Symptoms appear only during periods of heavy abuse or sudden increases in potency and are reduced after drug abstinence. Antipsychotics may or may not improve the symptoms. As I showed in the first case, often visual hallucinations are prominent in cannabis psychosis. In that first case, the pictures were coming out of the walls for her, or living people were coming out of the pictures. She had insight, and her thinking was more organized and sequential. She had no family history of psychosis, premorbidly well adjusted, and she did not have any schizotypal features. So these are some of the clinical features that can help us. Let's think of another case. 18-year-old high school junior with a history of ADHD and a seizure disorder in childhood. She's brought by parents with a 1 month, he is brought by parents for a 1 month history of responding to visions and voices, several cartoon heroes. He is self-absorbed and often smiles to himself. 1 year prior to presentation, without any apparent reason, he has become disinterested in school and has been watching cartoons and our other programs with magical themes more frequently. So he had slightly delayed language milestones, was less interested in socializing since childhood, more interested in, he was really a master. He would just look at a map and be able to tell you where is what city or what street and what highway and so forth. He was resistant to change and would start crying if the mother ever forced him to interact with any person who was not familiar to him. His school performance was below average. He had been treated with stimulants between age 8 to 12 with some benefit. So that's the story. So let's look at the questions. So do we have the answers? Yeah, so the majority of you, in my view, correctly diagnosed him with autism spectrum disorder with psychosis. It's not always this easy, but in this case, it was made easy by the fact that he had many of the hallmarks of an autism spectrum disorder, going back to childhood, delayed milestones, resistance to change, some speech difficulties, and psychosis in patients with autism spectrum disorder often take the form of magical preoccupations, cartoon heroes, and so forth. ADHD is highly comorbid with autism spectrum disorder, and he had some seizures as well. So the picture is fairly clear cut. And this is something that you will probably occasionally come across in clinical practice.
Kesh,
Yeah. Yes.
sorry, so I have a quick question with that, because actually, from my sense from what was up there with the vignette, in terms of the responding to voices and visions, well, that certainly sounds psychotic. A
Yes.
lot of young people on the spectrum have very active fantasy lives and often
Yeah.
are very caught up in them. And on top of that, I think if they are having, like in particular, any violent or sexual urges that to them seem inappropriate to have,
Yes.
they can often be quick to kind of attribute it to an external source like a voice.
Yes.
And so at least in my practice, in my work, a lot of times what I look for is more like substantial changes in the functioning as well as the thought process. Like a lot of
Yes.
people on the spectrum clearly have idiosyncratic thought processes to begin with.
Yeah.
That can be odd, but they're like really asking the family, like, has there been a change in that? Because a lot of things with the cartoons and things, I think they're like, while they have their restricted interests, their restricted interests can change over time. That can make
Yes.
it complicated because it can seem like a psychotic preoccupation.
Yes.
So kind of I think that definitely would be something that I would be watching for very closely.
Yeah, that's a very important point you bring up. What you're saying, Fred, is that this kind of a psychosis-related picture in and of itself is not uncommon and can be consistent with an autism spectrum diagnosis. But you would begin worrying about a primary psychotic illness if there was more of a functional decline on top of that. Is that correct?
Yes, exactly.
Yeah, I think that's a very helpful point. Yeah, thank you.
And there's the other thing, though I know it's somewhat backwards, that I just end up finding helpful in these instances is like working backwards from the medications, and that
Yes.
if it was more like a psychotic process was occurring, an antipsychotic, you'd expect to see improvement and change relatively quickly. Whereas if it was more like people being enthralled with their own fantasy life while still having intact reality testing, I wouldn't expect to see much of a change with an antipsychotic, with the exception of potentially like if they struggled with episodes of dysregulation, then them having fewer issues with that, but not like a global change.
It's an excellent point that you bring up, which may be worth empirically testing in the literature. And that is, if it is a primarily autism related psychotic regression, it may not respond as well to an antipsychotic, whereas if it is primarily a schizophrenic illness, it might respond better, is what you're implying. Is that correct?
Yes, exactly.
Yeah. The only way I would qualify that is even primary schizophrenic illness, if it is accompanied by a background history of autism, tends to be non-responsive to antipsychotics.
Well, in there I can mention, so I had a case that was actually had a lot of similarities to this, and actually had never been diagnosed with ASD. That was pretty remarkable, but it was something that we hadn't seen much improvement with an antipsychotic.
Yeah.
And so then I actually, because the attentional impairments were so pronounced, we ended up trying a stimulant. And with the stimulant, they actually clearly became more disorganized and clearly responding to internal stimuli. And so it was kind of something that, like, with the medication trial, it kind of declared itself more. And kind of as you just said, with the antipsychotic, there wasn't a huge response. But it was something that after trying the stimulant, it seemed pretty clear that
Right.
it was autism spectrum disorder with a now emerging psychotic process.
Fascinating. Yeah, thank you for bringing that up. So in someone who's not responding to antipsychotic treatment, we should kind of scratch our heads and think about whether this is a diagnostic mistake, and we should be thinking of autism spectrum disorder and look at other possible interventions. Thank you. Okay, so let's move on to the last part of my talk. Is the psychosis not better explained by a primary psychotic disorder or another mental disorder? So here, let me throw another case at you all. So this lady, 22-year-old woman, presents with two voices, one of the angel with soothing words and another of the devil telling her to burn in hell. When she turned the tap on to shower in the morning, blood gushed out of the taps. Further history reveals similar episodes with psychosis and depressive symptoms, typically lasting a few hours, in the context of on-off relationships with her boyfriend. Examination reveals multiple cuts on her wrists. Medical history is unremarkable except for febrile seizures in childhood. So let's have the next survey. I wonder if it is the wrong survey. Let's see. Was there one before this?
Let me check. I'm gonna stop it.
I would say that the options seem to make sense and match up with what's on here now.
Yeah.
Yeah. Oh, I guess I don't think there's a survey for this one. I apologize.
Okay. All right. So, yeah. So here the options are right there on this slide. So is this a temporal lobe epilepsy? Is this psychosis NOS, or is it a bipolar disorder, or is it a borderline personality disorder? Any of you could speak up or put your diagnoses in the chat. I can show the case back again if people have questions.
To me, there definitely is some features of borderline personality disorder, which yes, I'm seeing some people say in the chat.
Oh,
but yeah,
yeah.
the psychosis features seem pretty, striking in
Yes.
the case.
So what is the one question you would ask in someone like this to further clarify the diagnosis? And I have the answer to that, but it is not in the case vignette described. What would you like to know further?
Well, so I guess on my end, one thing that I'd want to know further, more than a question, would just be from observation
Yes.
in terms of how the thought process is. In that
Yeah.
if there weren't, I've found it to be exceedingly rare, and actually probably rarely have ever have found that someone who's describing really active auditory and visual hallucinations would be saying those things without having any kind of notable thought disorganization on mental status exam.
Yeah. So the
but-
answer to that is that she had, she was very articulate and had no evidence of any thought disorder.
Yeah, and that would make me think much more of the micropsychosis.
Yeah, absolutely. So I think that's a critical questions. Affective blunting, formal thought disorder, the presence of delusions and hallucinations that are persisting beyond any specific triggering psychosocial events lasting more than a few hours. Those are all the features that you would make you think of a more primary psychotic disorder. In this case, it was very clear cut. The psychosis lasted just a few hours, always in the context of a broken relationship with her boyfriend, and always, the content was very congruent to her stress and her thinking, and very dramatic, and quite often like blood gushing out of the taps. That kind of thing you would hear from people with personality disorders, much more likely. So that's one example of psychosis that could be better explained by another psychiatric illness. Let's take another one. This one, the survey that you sent out is not appropriate for this case. So do we have the answers now? Yeah, so again, as I was expecting, the majority of you, 75% of you, diagnose this as psychosis secondary to bipolar disorder. It's important to keep in mind, how do we go about making that distinction? And the next slide will actually be helpful to understand that. So let's see here. So when you're diagnosing someone who presents with both psychosis and affective syndromes, ask the question as to whether the depression or the mania happened only briefly in the context of a overall psychotic illness. The second scenario is the psychosis is intermittent and there is a mood syndrome that accounts for a substantive proportion of the psychotic illness and outlasts the psychosis for at least a couple of weeks. The third scenario is the psychosis comes only in the context of either a depression or a mania. And the fourth one, so the third one is psychosis only in the context of a depression. And the fourth one is psychosis in the context of either a depression or a manic episode. So what would be your diagnosis for the top one, scenario number one?
And can you clarify, Kesh, the black line?
The black is the psychosis,
Mhm.
blue is depression, red is mania. So the top one would be a, sorry. The top one would be schizophrenia with superimposed depression. The second from the top would be schizoaffective disorder, because there is a depression syndrome that has been in existence outside of psychotic episodes for a significant portion of time. And the overall mood syndrome is there for a substantive amount of the psychotic illness. And then you have depression, psychosis that happens only in the context of a depression, which you would consider with major depression with psychotic features. And the bottom one is psychosis always occurring in the context of either a mood or manic or a depressive syndrome. And that is bipolar disorder with psychotic episodes. So in practice, one comes up with the variety of the shades of this kind of presentation. And it would be useful to make these distinctions because they may help appropriate treatment selection. So let me summarize again before we maybe have a few minutes for discussion. Always ask the question, is this psychosis? And if it is psychosis, is this better explained by a medical illness, another substance abuse disorder, or a developmental disorder? If the answer is no, ask the question whether there are prominent mood symptoms, either along with psychosis only in the context of a mood disorder, psychosis always appearing in the context of a mood disorder, or whether there is psychosis independent of the mood disorder as well for at least a couple of weeks at a time, in which case you consider schizoaffective disorder. If the psychosis is not accompanied by prominent mood symptoms, ask the question whether it is primarily a non-bizarre delusion that accounts for the majority of the symptoms, in which case you consider delusional disorder. If that is not the case, then the next set of diagnoses will depend on the duration. If it is less than 6 months, but if it's less than 1 month, you consider a brief psychotic disorder. If it is 1 to 6 months, you consider schizophreniform disorder. And if it is more than 6 months with a functional decline, you then make a diagnosis of schizophrenia. And then in order to make a definitive diagnosis of schizophrenia, you need to show that at least 2 of the symptoms in this list of hallucination, the negative symptoms, loose association, delusions, and order disorganized behavior, at least 2 of those in DSM-4 should be present. In DSM-5, the one specific, special status that had been given for bizarre delusions is now taken away. So in DSM-5, you just need two of these criterion set A symptoms. Doesn't matter if it is bizarre or not bizarre. DSM-5 has taken away the special status that had existed for the so-called first-rank symptoms like thought broadcast and thought insertion and so forth. When you can't make up your mind still, you always have that category called psychosis not otherwise specified. But, we all should strive to make a diagnosis that is more specific than a psychosis NOS. And often the diagnosis of psychosis NOS is a reflection of us not spending enough time with the patient. The more you get to know the patient, the more clear-cut the diagnosis becomes. I think that's my last slide. And I want to thank you all for your attention, and I will stop sharing so we can address any questions that folks might have.
I have a question about the uneven pupils you mentioned. I'm unfamiliar with that and what that might indicate.
Yeah, so this is not a common problem. There are some congenital conditions with an unequal pupil that can present themselves with neuropsychiatric disorders. But I'll tell you one dramatic case that I had seen where the unequal pupil gave away the diagnosis. So this was a man in his 40s who was brought into the emergency room with grandiose delusions. He had been drinking heavily and had fallen on the side of the street. And he was, of course, very disorganized in his thinking and rambling in his speech. Physical exam revealed everything else fine except unequal pupils. So we got him scanned just in case, because he had fallen on the roadside. It turned out that he had a subdural hematoma. He had a bleed in his head, which was pressing the optic nerve, the oculomotor nerves on the one side, because if the blood accumulates due to the subdural hematoma, it moves the brain to one side and it compressed one of the nerves in the eye, and it caused the pupillary dilatation of that eye. And that's how the diagnosis came about. So in a physical exam, one should always be looking for these kinds of things. But thanks for that question. Yeah.
I had another one related to the last slide that you showed, which you didn't touch on in this talk, but the line going off to delusional disorder talks about non-bizarre delusions. I guess, in my head, delusions are by nature bizarre. Can you talk a little bit more about that?
Yeah, so if a person says, Nobody likes me in my work, and people are jealous of me, and so they are demoting me as a result of that. And let's say that you verified that by collateral information that was not true. Nobody was deliberately trying to demote him and so on, but he wouldn't stop talking about it. So ask yourself the question: is this plausible? The answer: it is completely plausible. People can get demoted, and but it was not bizarre. It was entirely plausible. So in this case, he would not stop talking about it for years, that whatever he did, people didn't like. So that was a non-bizarre delusion. He had a delusional disorder. This is
So
different.
really that relies on external input because, what they're saying very well might be true. Yeah.
Yeah, exactly.
So one question, and I apologize if this was answered and I may have missed it, but with the idea of cannabis-induced psychosis, if it's solely cannabis-induced psychosis, how long would you anticipate that would take to clear?
Well, there is the standard teaching and there is the reality. The standard teaching is if a person's psychosis has outlasted over 6 to 8 weeks after the last use of cannabis and the patient still reports delusions and hallucinations, you should begin thinking about a primary psychotic disorder. But then, more recent data seem to suggest that cannabis-induced psychosis can also last more than several weeks beyond the cessation or abstinence from cannabis, and may take more than a couple of months to clear up. So there is no perfect answer to that question. Probably more empirical data are needed. But a lot of these patients, according to the research studies, seem to suggest that there may be a primary psychotic illness that is triggered and follows heavy cannabis abuse and appears to persist beyond a couple of months. And they may be better characterized as schizophrenia anyway, because behaviorally, symptomatically, phenomenologically, they look like schizophrenia. And cannabis happens to be one of the etiological factors, just like genetic factors might be an etiological factor in a good number of cases. Cannabis is also an etiological factor. So if you consider a diagnosis that is made agnostic to the etiological factor, they have schizophrenia in essence. That is to be distinguished from the kind of patient that I described, where this lady had psychosis only as long as she was using cannabis, and it completely cleared up without any antipsychotics within a few days of stopping the cannabis. That's a different matter. That's very straightforward. So there are straightforward cases where cannabis triggered the illness. And I'll give you one example. Back in Detroit, I had seen a patient who was sent to me for a second opinion because this patient had stayed in the mental hospital for like 15 years after when the psychosis had started in the context of heavy cannabis abuse. And nobody ever bothered to get the person off of an antipsychotic for all those several years, and just kept on treating him. And because he did well and he liked the medicine, he kept on asking for more Haldol. And so his Haldol dose had become like close to 100 milligrams a day. So the second opinion was to ask whether he really has cannabis or not, has psychosis or not. So we admitted him. Those days we had the luxury of admitting them in the research ward. We admitted him for a couple of months, took him off all antipsychotics. And of course, he had never gone back to cannabis. And promptly within a couple of months, he began experiencing psychotic symptoms. So there was a primary psychotic illness in that case. So often the diagnosis is given away by a relapse that happens in the absence of cannabis. But in any cases, the ambiguity might remain.
Thank you. That's very helpful.
Yeah.
Because in my sense, working on the adolescent inpatient unit there with people who use heavy cannabis who came in, usually my approach, if I was able to, was to try to observe them for a few days without antipsychotics.
Yep.
In the absence of cannabis, and not even to see if the symptoms completely abated, but to see if there was even any improvement.
Right.
And often just have found, being on the other end, on the outpatient end, there's been, it seems like in first episode patients, most providers feel much more comfortable because of a lot of the stigma and other reasons, using the label substance induced, as opposed to schizophrenia. And yeah, I think that there are situations where that can be helpful because families need more hope, but other situations where it can actually be kind of undermining and feed into denial on the part of families. And also like just the whole like more expressed emotion in a negative light towards the young person in terms of like you caused this to yourself, that then just seems to very quickly not be helpful for anyone.
Yep, like that's very helpful. And sometimes, you know, the diagnosis is very difficult to make because we don't have the ability to keep patients and observe without antipsychotics for a lengthy period of time. So this first patient that I described, just to tell you a little bit more detail, whom I managed as an outpatient. She came with heavy cannabis use and psychosis in that context. And I told her, look, I will see you 3 times a week. And each time that you come to the clinic, I will do a drug screen. And I'll be rating your psychosis severity during that period of time. So she came consistently for like a month, like 3 times a week. And we checked her urine drug screen, and it slowly started going down, the THC concentration. And she was completely clear in a couple of weeks' time. And the BPRS scores came down like a straight line from a score of around 70 or some equivalent of 45 or something like that to below 10 over a period of 2 weeks time, in the absence of antipsychotics and in the absence of cannabis, which was confirmed by urinary drug screen. So one can do that kind of an experiment in cases where there is doubt. I think we are at our time.
Yep, we're right at 12:30, but yeah, thank you, Kesh, and everyone. So we will see everybody back in January, and before then, we'll also be sending out a survey. So we want to hear people's feedback on topics that they would be interested in hearing about in our next year of these talks. So keep an eye out for that, and thanks for joining us today. And thank you, Kesh.
Thank you.
Thank you.